Good afternoon, everyone, and thank you for joining today's webinar, Exploring Links Between Physician EMR Use and Care Quality and Productivity, where our analysis of the 2014 NPS data will be looking at advanced use of digital health functionalities in Canadian primary care settings. I'm Chad Lever from Canada Health Infoway, and I'll be introducing our other speaker in just a moment. I want to let everyone know that we will be recording today's session, and we will be posting that online on Infoway's website. Again, as our host has mentioned, that you use the Q&A panel if you want to ask a question during the session. Our requisite disclaimer for the presentation, please take a moment to read that over. And again, if you want to ask questions, do so through the WebEx. There's a drop-down arrow to select Q&A, and you would want to send the question you have to all panelists. So today's session will be looking at an analysis we have done with the 2014 National Physician Survey. As many of you may know, this was released in 2014 in December. Over 63,000 family physicians and specialist physicians across Canada were eligible to respond, and over 10,000 completed the survey with a 16% response rate. For family physicians, the response rate was 15%, and for specialists, it was also 15%. These are national level estimates based on NPS study results that we'll be reporting here today, and they're considered accurate within plus or minus 1% 19 times out of 20. Our guest speaker, Jeremy Smith, will be presenting on EMR optimization through post-EMR implementation support, a BC PITO program. And we have question and answers directly following that. And I'll point you at the end to some available resources as well. Okay, so today's presenter, hi everybody, I'm Chad Lever with Canada Health Infoway, Benefits Realization Leader, and Jeremy Smith, Program Director from PITO and Doctors of BC is my co-presenter. I also want to acknowledge Mona and Dragan from the College of Family Physicians of Canada, the National Physician Survey, for supporting the analysis that we are presenting today. So thanks very much to Mona and Dragan. So, primary care use of electronic medical records in Canada has increased substantially over the last 10 years. Shown here, data from the NPS 2014 and as far back as 2004 and the Commonwealth Fund surveys illustrate the trajectory of EMR adoption in primary care, where in 2014, 77% of all practicing family physicians are reporting EMR use in their practice. This next slide shows EMR use by province in 2013, the orange bar, and in 2014, the blue area. And in brackets at the bottom is the year in which the provincial EMR program was initiated. EMR programs were or are supported by Canada Health Infoway and the provinces with the aim to increase EMR adoption in that province. The provinces with earlier EMR program start dates are now in about the 80% range, and interestingly enough, in comparison to 2012 Commonwealth Fund data, that even exceeds what we see as the EMR adoption rate in Germany in some of these provinces. Newer programs like those in Quebec and New Brunswick demonstrate a substantial growth in the last year, and that's the blue area there, now at 58% in Quebec and 63% in New Brunswick. The focus of our analysis presented here today is on family physicians who use an EMR and the self-reported impact on quality of care and practice productivity. Again, we included family physicians in active clinical practice who use an EMR to enter or retrieve patient notes. And the specific questions we were looking at was, as stated in the questionnaire, how has the quality of the patient care you provide changed since electronic records were implemented on a scale of much better to much worse? It's a 5-point scale. And for productivity, the question was, since electronic records were implemented, the productivity at your medical practice has greatly increased or greatly decreased, again, on a scale of 1 to 5. We were interested in the impact of years using an EMR and the use of multiple functionalities on these specific quality and productivity self-reported variables. And here are our results. In 2014, the majority, 52% of family physicians, report the productivity of their medical practice has increased since EMR implementation. Nearly a third, 28%, report no change in practice productivity, and a fifth report a decrease. Overall, 76% of family physicians report that quality of care they provide their patients is better or much better since EMR implementation. We were interested in exploring the impact of whether years using an EMR impacted physician perspectives of realizing improved practice productivity and quality of care. And our results suggest that a number of years using an EMR really does have an important impact on physician-reported practice productivity and the quality of patient care they provide. 36% of physicians who have been using an EMR for less than a year report improved practice productivity compared to physicians who have been using an EMR for over 6 years, where 61% report improved practice productivity. Physician-reported impact on the quality of care they provide their patients is actually fairly high off the mark, at 60% of family physicians using an EMR for less than a year reporting quality of care is better or much better. 85% of family physicians with more than 6 years of use say the quality of care they provide is better or much better. We know from the literature that achieving productivity and quality of care outcomes through EMR use requires important support with regard to workflow integration, technical training, improving EMR data quality across large practices with perhaps variation in physician use, of which there have been a variety of programs and initiatives across Canada, such as peer-to-peer networks and the support program my colleague Jeremy will present about in a moment. We were also interested in understanding the impact of physician use of various functionalities in the care of their patients, and the MPS asked physicians about the use of 14 different functionalities in the survey. This next slide shows in the orange and blue areas that more functionalities physicians use in the care of their patients, the more likely they are to report that the productivity of their medical practice has improved since EMR implementation. The bundles of functionalities along the left-hand side represented in the 1 to 5 bundle, they tend to be those that are indicated in the clinical patient profile, such as entering clinical documentation, electronic receipt of lab information, list of medications, etc. Functionalities in the 6 to 10 bundle are those related to those in the 1 to 5, as well as ordering lab tests, referrals, and communicating interventions. And functionalities in the 11 to 14 bundle, again, include the core set of functionalities from 1 to 10, and also tend to include things like decision support, patient safety, interoperability, such as use of warnings, reminders, and decision support tools, and interfaces with health professionals, etc. The next slide shows that the use of multiple functionalities and physician-reported impact on the quality of care they provide. We see the same as true, that the more functionalities primary care physicians report using, the more likely they are to report that the quality of care they provide to their patients is better or much better since implementing an EMR. Indeed, 86% of primary care physicians who report using up to 11 to 14 functionalities in the care of their patients say the quality of care they provide is better or much better, compared to 53% of those who report using between 1 to 5 electronic functionalities in the care of their patients. In the presentation deck that will be posted following our presentation today, there are descriptive results of the specific functionalities used across these quality and productivity slides I've just showed you. In summary, EMR use has increased across Canada rapidly in recent years. Many physicians report short-term quality of care and productivity gains, but perceived benefits of practice productivity and quality of care tend to rise as practices gain experience and broaden use. This reinforces the importance, of course, of continued focus on practice transformation and change management to optimize benefits. With that, I'd like to turn it over to Jeremy Smith from Doctors of BC and Pedo.
Thanks, Chad. Okay. So first, I'm going to share a couple of slides on the context in BC, because it certainly, like Chad says, does impact meaningful use and optimization of EMR depending on level of use, years of use, and also the level of interoperability that's available. So I can speak to those three very briefly. Reflecting on our experience, I've heard the phrase several times, it's a journey, and it truly is. If you look at these three curves indicating that there's sort of initially gradual uptake of something, then it really starts to escalate, and then it sort of tapers off towards the end, and you'll get the last few laggards, sort of like the bell curve of adoption we often see. I've simplified it in this way. EMR adoption, as Chad says, we're at 85% in many of the provinces that are further ahead, including BC, of all eligible physicians. If we exclude those that are over 65 and so on here in BC, we're actually over about 94% as of right now. So we really are into the last trickle, and that number isn't changing. And that's held out by the National Physician Survey as well. One of the questions that Chad didn't mention was, of those that haven't adopted the EMR, are you likely to in the next 3 years? Only 25% said yes. So that holds out that curve. We're now into the focus on meaningful use, and we're well up that trajectory, as you'll see in the subsequent slides. There's still a little bit more room to go before we truly start to taper off, but we're starting to see the same thing. The ones that haven't participated are the ones that really aren't interested in working on proactive care or quality improvement to the nature of their practice. And then in interoperability and analytics, we're on a similar curve, but we're probably even a little further back on that. We've got quite a bit in place in BC, but still room to go. So a little bit more detail. What I'd like to focus on is just the two main numbers there. You'll see 93% of our target physicians in BC are now on EMR, and 82%, actually 84% as of right now, are on EMR. I include all the numbers just so you understand the context of that we do have 11,000 physicians in the province, but we're focusing on those that would be eligible for an EMR, i.e. excluding those ones that are in hospital practice or diagnostic practice like lab and radiology. Interestingly, now in BC, the adoption amongst full-service family practice physicians and specialists is almost the same. I'm going to be focusing in this presentation on full-service family practice GPs, but I'll make a couple of comments on the specialist side as we go as well. The specialist adoption was lower initially and really has caught up. But particularly, you notice the change by size of practice. We often compare ourselves to other countries who quote near 100% EMR adoption, but they're typically in environments where they've moved to larger group practices, much more structured full-service family practice environments, and so on. When you actually compare apples to apples, we're right up there with the leading countries now. What's particularly interesting, though, is then when you look at individual communities, we have some communities that are at 100% and have been for 5 or 6 years. We have other communities which are still down around 75%. So there's definite variation across a province. It's not like it's just 93% across the board. We also have a very stable EMR marketplace in BC. There's about 8 vendors that represent 94% of the market share and 5% of the market share. And those numbers have remained remarkably consistent over the last about 4 years. Obviously, in the initial uptake, the numbers varied a little bit, but they haven't changed terribly much in the last 4 years. And all of these EMRs now are robust solutions. They're vendors that we've worked with quite extensively, et cetera, et cetera. We also have nearly ubiquitous results and reports delivery in the province now, which is very important for achieving EMR optimization and meaningful use. I'm not going to speak to the details of this slide, but just if you get a sense of all the check marks across the top with lab results delivery, lab results are available ubiquitously across the province now through basically 2 different broker solutions. Diagnostic imaging results are almost ubiquitous across the province. Transcribed report documents really are almost ubiquitous across the province, and now the health authorities are moving into notification of admission and death and discharge to support shared care. So physicians now on EMR can get most of the information they need electronically delivered to them for tests that they have ordered or for their patients that go into hospital. That doesn't mean that we have everything in place for prescribing and referrals and so on yet, but this core results and reports delivery is pretty ubiquitously in place. So with that context, I'll talk about what we've referred to as meaningful use, or Chad referred to more as optimization, but the two are basically synonymous. What we heard from physicians, not even after EMR adoption was sort of complete a year ago, but even before that, they'd implemented and they'd been live for 2 or 3 years, and then they'd be sort of knocking on our door saying, hang on a second, don't go away yet, I still need help. I'm still struggling with some of the fundamentals. So we stopped and said, okay, what are we going to do about that? We did what we called a series of small maximizing clinical value pilots. clinical value phrase came from Infoway's use of the phrase clinical value, or equivalent to meaningful use. And we started these pilot projects truly as pilots. Like they were the quintessential example of a pilot project, something you try, small, innovative, and see what happens, because no one had ever really done a post-implementation support program like this before. It was quite new. So we tried a number of different things across the province in small examples and saw what worked. What we observed was a huge degree of variation in use, from minimal to advanced. It did correlate somewhat to years of experience using it. It also correlated very significantly to whether the practice was particularly focused on full-service family practice care versus, say, walk-in care, whether they were focused on proactive care and quality improvement. That gave them the motivator. But the variation was significant. Notably, that variation was even significant within clinics and within communities. We'd have a community where they were 100% EMR, had been for ages, had been doing user groups, sharing information. We had clinics that were considered the most advanced in the province and had been on EMR for years. And then we'd find out that one physician in that clinic was still barely using the EMR, despite the colleagues being so advanced. We also had a number of physicians shockingly struggling with the basics. I'll show on the next slide the meaningful use diagram, and we still had physicians at meaningful use level 1, barely using the basics, not even entering prescriptions because they were struggling with how to do it. In particular, one that sticks in my mind is one very advanced group practice. I think it was 6 physicians. They pulled out of their EMR all of the diagnoses and did an analysis and found that amongst the 5 or 6 of them, they were coding diabetes 32 different ways. So there is no way they can do meaningful quality improvement work on diabetes or even proactive care around diabetes, which is founded around having a registry of your diabetics, if you're coding them 32 different ways. Bottom line was, the data in the EMRs was not sufficient for valid quality improvement indicators. You can develop all sorts of nice sophisticated technology solutions for big data and analysis and so on, but if you're finding that physicians simply aren't even entering information or doing it highly inconsistently, those indicators are not going to be valid. So as a result of that early work, we then designed what we called our post-implementation support program. It was based around this meaningful use model, which came sort of spurred initially from the US HIMSS MRAM model, the ambulatory care meaningful use model. We tailored it a little bit more to Canada. It was also informed by the US HITECH Act meaningful use definitions, and some work out of UVic. And then we also later collaborated with several of the provinces across the country and COACH on the national meaningful use definition, which is almost identical to this model that you see here. Level 1 is just front office automation. They really aren't using EMR as such. They're mainly using the billing and scheduling. Level 2 is EMR basics. They're basically using an electronic version of a paper record. They're still typing in their encounter notes, really not entering structured medication lists, allergy lists, and so on. They might as well be using paper. They're just doing it on a computer. Versus level 3, where they're what we would call a full EMR. They're capturing all structured patient profile information, allergies, problems, immunizations, et cetera, et cetera. That's what we would consider a foundational level of meaningful use. Once they're at meaningful use level 3, they are fully using the EMR, and they are ready to start using their data and functionality for levels 4 and 5, proactive care and community shared care. But unless you're at that level of foundation, you can't really get to the next levels. So that was the model. We then designed the post-implementation support program, which would take a lot longer to describe in detail, and it wouldn't be me to do so, but I'll give you a quick highlight of the kinds of things that we provided. This picture is right off our website, and you're welcome to look at our website for more information. There are 4 or 5 steps in the process. We have team members called PACs, Practice Automation Coaches, who go to the clinic and do an in-person assessment. That was a very important part of the process. If it's a large group practice, you see the note on the left here, practice optimization session. If it's a large group practice, they start with a practice optimization session with the group as a whole to understand the group as a whole, understand what their goals are as a clinic, if they're operating truly as a group clinic or just a group of individuals, and set the context for the next step. They then go in and do the initial assessment, which is a subjective assessment. It's an in-person survey with the practice, and I'll show you an example of that in a moment. From that, they co-produce with the clinic a customized practice optimization plan. So the clinic has an actual plan to refer to of things that they want to work on. It has their practice goals, the individual gaps that were identified in meaningful use, and what they're going to do about each one. And then the tools at their disposal are physician and MOA peer support, which I'll speak to again in a moment. They can get additional vendor training if it's functionality support that they need. The PAC, Practice Optimization Coach or employee, often will go back in and help them with some workflow or some basics. Importantly, they clearly differentiate their role from the vendor. They are not there to do application support, but they can help the clinic with some workflow issues or some tips and tricks. And then we also provide EMR user groups, which have been very useful, where physicians in the community come together to share experiences and knowledge, both physicians and MOAs. Our practice optimization coaches then go back in and do a progress assessment a few weeks or a few months later to find out how the practice is doing, give them a little reminder, give them a little nudge, help them along. If maybe they're struggling, figure out what they can do to help them. Throughout that, we also have something called the ODD, the Objective Data Dashboard, because as I mentioned, the initial assessment is subjective. They can also now bring up a dashboard, which I'll show you in a couple of slides, which is truly objective. It is data straight out of the EMR that shows them how they are actually doing. Are they actually entering meds, actually entering allergies? And it serves as something that they can pull up and look at any time themselves, so it's a self-coaching tool, and it's a truly objective measure. So they may have said they were doing it, but are they actually doing it? Peer mentors have been absolutely central to this process. We have both physician and MOA peer mentors in BC, and both have been really important to the process. They've had a number of different roles. I mean, if you go way back, they were involved in promotion of EMRs and then adoption of EMRs. But as it relates to post-implementation support, they have provided a huge amount of in-practice coaching. They go into the clinics and provide support from a clinical context. And that's what physicians seem to have valued more than anything, more than vendor support. Usually they're not struggling with the actual EMR functionality. They're struggling with how to apply it in clinical practice. We've also, peer mentors also lead and facilitate the EMR user groups. That's a very important part. We don't run a user group if the physician isn't leading it. They also operate as community leaders and champions. That we form these things called communities of practice, where physicians lead them in the community, and then since then the local divisions of family practice have formed. And we've also had peer mentors involved as experts in the design of the program. For example, I'll show you the ODD in a moment. They designed the ODD, they designed to determine what metrics were relevant and what the thresholds should be in those. We also established more recently what we call an MOA learning series and network, because we realized that the MOAs were a really critical group for engagement, particularly as you talk about practice optimization and office efficiency. And as I mentioned, I'm focusing on in these slides on the GP program, but we provided a parallel program for specialists. And specialists are much less likely to participate in these kinds of things than GPs are. And in a specialist's office, the workflow is much more MOA focused than it is physician focused. The EMR use of it, should I say. So in engaging specialist practices, the MOAs were really important. We also see that peers are important because they also sustain the change in the long term. We're here doing a project, getting physicians up to a level of meaningful use. The peers need to take a lead in helping their colleagues and pushing things ahead in the long term. So I mentioned the first step in the process is the subjective assessment. Our team built an online web-based tool. They started actually with an Excel spreadsheet, which was very sophisticated and complicated, but they then decided that themselves that they wanted to use a web-based tool so that they could bring it up on an iPad or a laptop in the field in a physician practice and complete the assessment. This shows you an example of the assessment for just the scheduling portion. And a couple of things I want to point out in here is these aren't just simplistic questions, do you use scheduling, yes or no. If you read a couple of questions, they're a lot more sophisticated to get at what's really going on in the clinic. For example, I work from the day sheet in the EMR. Our practice is able to search for the next available appointment. Our practice records the visit type. Our practice configures scheduling alerts. Those are prompting questions to really understand what's going on in the practice. And then if you look at the response, it isn't just yes or no. you only see two of the examples here, 1 and 2, but it is yes, the process is fine, or yes, but the process needs improvement, or no, I need the EMR vendor functionality needs to be improved, or no, I really don't understand how to use it. So it gives them options to give a much more intelligent response as to what the issues are. This is the result. I've blocked out the vendor names with EMR 1 through 11, but this is by vendor, what the impact has been on clinical effectiveness and practice efficiency. Key thing here is you see all the red. At the initial assessment, 16% of physicians were at meaningful use level 3, like really, really low. And their average score was 2.4, so well below a fundamentally basic level of use. Next slide, you notice all the green. By the progress assessment, physicians were on average scoring 87% at meaningful use level 3. And their average score had gone from 2.4 up to 3.6. So clearly from the 2.4 up, support was needed. And from the change from 2.4 to 3.6, clearly the program was having a significant impact. But that's just the subjective. The next slide shows the objective data dashboard, because despite, as I described, the questions being very carefully designed and insightful and all that, you still don't know until you really see the data as to whether the functionality is truly being consistently used. So we brought together a group of 16 physicians to decide what data elements in an EMR really needed to be entered and entered consistently to define truly meaningful use, so that you had the data you needed to be able to do proactive care and quality improvement and so on. And you'll notice if you've had any exposure to the CIHI primary care data set, there's a high degree of correlation. Things like smoking status, vaccinations, allergies, procedures, referrals, height and weight, etc., are the things in here. And so they identified the 13 or 14 different metrics, and then they defined a threshold, a minimum requirement to be considered at meaningful use. And it's important that that's not a target. The target would be like a clinical target that you want to get X percentage of your patients, diabetics, having had a hemoglobin A1C test done. This is a minimum threshold. If you've entered prescriptions for at least 40% of your patients, you're probably at a fairly high level of meaningful use, because you wouldn't expect 100% of your patients to have a medication. That would be actually a bad indicator, not a good one. What was really important about this, is that physicians thought they were doing quite well on the subject assessment, and then probably about 50% of the time, they then go to do the objective assessment and realize that they had a pretty important gap. The adoption rate was pretty low initially. Physicians didn't really understand why this was important. There's a degree of skepticism, and the adoption rate's gone up dramatically. This chart shows the number of ODD submissions. We don't ask them to submit their interim score. We only ask them to submit their ODD showing that they are at level 3. This was as of 2 weeks ago when the Infoway folks needed the slides. That number is now, so this afternoon, will be about 1,600. The increase has been exponential. Interestingly, the more it's got used, the more support and interest there's been in it. My general assessment is that it's provided physicians with something tangible. Previously, they were just saying, oh, I'm struggling with my EMR, I've got challenges, they're always working okay for me. Now they've got something tangible. They can look at their ODD and say, oh yeah, I really do need to work on smoking status. That's pretty important to me. And I can see that I've got a gap. And also, very importantly, it drives competitive spirit. You can put all the other stuff aside of funding and incentives and so on, but when two physicians get to share their data between them and say, well, I'm at 3.6 and you're at 3.2, well, geez, I want to get from 3.2 to 3.6. We had emails flooding in from across the province, from little tiny towns and big cities, of physicians saying, well, how do I get up to that next level? So it really did drive the competitive spirit. The physician feedback overall has been extremely positive. At the end of the subject assessment process, we divide their incentive funding. They can get $3,000 for reaching level 3. Once they complete the subjective process, the subject assessment, the optimization work, and the reassessment, they can get $1,000 of that $3,000 as a sort of an advance to recognize their time out of practice. The other $2,000 they can't get until they've completed the objective data dashboard and shown that they're truly at level 3. But to get that first $1,000, they have to complete the survey. to complete receive the 3,000 also have to complete the survey. So we've got a very, very high response rate. These numbers, this shows response to 955 physicians. We're now up around 1,400, I think, or more. But the response rate has been incredibly positive. You see on the left there, your overall experience post-implementation support, 87% said it was either good or excellent. That's pretty unheard of for a support program like this. On the right-hand side, this correlates to Chad's point about perception of impact on care from the National Physician Survey. Do you think the EMR better assists you in enhancing patient care as a result of post-implementation support? 83% said either moderately or significantly. 40% said it significantly enhanced their patient care. Again, pretty remarkable. And the anecdotal comments were also phenomenal. More often than not, what we heard was, I didn't know what I didn't know. They said, I just had no idea that I wasn't entering these things consistently and what impact that was having on my quality improvement metrics. We also consistently heard people saying that the EMR is now working for them, not them working for it. That was less frequent than the first comment, but that was one that really stuck in my head because I saw it quite a few times, and it struck a chord that a lot of physicians were feeling that way, that they were working for the EMR. So our lessons learned. One challenge is focusing on meaningful use level 3 versus the 4 and 5. The 4 and 5 is the stuff that's really clinically exciting. A physician wants to be involved in quality improvement, proactive care, shared care. Those are the things that have a really tangible impact on quality and patient results. The problem is you can't get there unless you've got to meaningful use level 3 first. So we spent quite a bit of time helping to inform physicians and others that it's really important to get to that foundation of level 3 before they try and attack the other. And you can do it the other way around by choosing a particular clinical topic. Say, we're going to focus on diabetes care right at the moment and make sure that we've got all the information related to diabetes care in the EMR, which is fine, and it has some benefits. But then the moment you then try and work on, say, improving care of COPD, you then have to go all the way back to ground zero and make sure that physicians are entering the diagnoses and procedures and medications, et cetera, related to COPD consistently. So we took the approach instead of making sure that they were entering all of the information at a reasonable degree of consistency so that they've got that foundation in place. Once you've got that foundation in place, it also lets you do practice self-reflection, because it's one thing if you're focusing just on diabetes, but most physicians want to be able to reflect on their practice as a whole, understand their patient panel, understand their diabetics, figure out where their gaps are. You can only do that if you've got broadly consistent information. As I mentioned, the ODD was embraced slowly initially, but proved invaluable for all the reasons I've mentioned. And it truly is the only way to effectively assess readiness for QI. We can now say definitively that the physicians that have participated here, which is the bulk of physicians, have the information that they need to have in place to do proactive care, to maintain registries, to produce quality indicators that are accurate reflections of their practice. Clinical terminology standards definitely remain a gap. The physicians on the panel for the ODD really wanted to have more requirements for fields to be coded. So I think, if I remember correctly, medications and diagnosis have to not just be entered, but to be coded. But if you look at our ODD, you'll notice that procedures has two metrics. One for procedures are entered at all, and another sub-B metric for whether they are coded, and the threshold for that is 0. So we put it there to start setting the expectation that it should be coded, but the reality is that coded procedures are not consistently adopted across EMRs yet. So that's a pretty key area of work, and I know Infoway and CIHI and so on have been involved in that. Probably the biggest thing at the end of the day is motivation. Out of 3,400 physician GPs in the province, we had 2,500 participating. That's a pretty high participation rate, but the gap of about 900 is physicians that just aren't that motivated to participate in this kind of thing. Either they're not working full service family practice care, or they're nearing retirement, or whatever the case, but they haven't felt the motivation to really engage in quality improvement and proactive care. And there's no point in banging your head against the wall with the technology part if the overarching environment of culture isn't in place. I'll leave you with one final thought, and that is something that struck me just a few weeks ago, that we've heard of a few studies aggregate studies of research papers saying that the research evidence isn't indicating, making assertions that research evidence isn't indicating the kind of impact on quality of care of EMRs that was anticipated. But when you've got the level of data that we have on level of meaningful use and where the gaps are, that isn't at all surprising. I think what the authors of those studies were missing was that it's sort of like strategic plans. You can do a strategic plan, but if you put it in the binder and put it on the shelf and never use it, it just grows dust. It's not much use. Similar thing with EMRs. But sure, we've got a high level of EMR penetration out there, but when you look at the details, you realize that most physicians weren't using the key elements of the EMR functionality that were expected to produce the benefits. So step one is getting the EMRs out there. Step two is achieving a level of meaningful use. And then you can start to assess whether, in fact, EMRs are having the impact on quality of care that were expected. And where that is the case, there are some very good studies that show that there is an impact. There are some good studies showing impact on, say, diabetes care or other work where they've got really good sort of big data analysis, identifying gaps and focusing QI improvement. And they have a pretty significant impact. But right across the board right now, you can't expect that kind of impact because there are so many physicians still using, well, at least until recently here in BC, very basic levels of EMR functionality. So I'll close by saying I mean, we were focused on EMR adoption from 2006-07 through till 2012. Starting about 2010-11, we started those maximizing clinical value studies concurrently with the last part of EMR adoption. In the last 12 months, we've been focused entirely on post-implementation support work. And I think as a result, we now have a stable and efficient day-to-day use of EMR in most practices in the province. 2 years ago, I was still getting phone calls and hearing anecdotal comments from physicians about how torturous their EMR was and the struggles they were having. And I just don't hear it now. Physicians instead are telling me when I cross them in the halls and so on, saying, oh, thank heavens, this has really helped me. We're really doing so much better now, and all sorts of good anecdotal stories, and we're seeing it in the data. We've also laid the foundation for quality improvement, interoperability, and analytics, because if you don't have good data in the EMR, none of those things are possible. You can't do quality improvement data because you can't get good metrics or develop a registry. You can't do real interoperability, such as, say, referrals or data exchange, because if the two physicians are coding things differently or not even coding them at all, you can't transfer them. And obviously, analytics, you need that kind of data. So I think that foundation is laid, so it'll be exciting to see the next steps. And that's it for me.
Great. Thank you very much, Jeremy. I'd like to invite our webinar members online to, again, put in any questions they may have in the Q&A section, and I'll be happy to read those off. In the meantime, while you think of a question, I have a few here, one for Jeremy. You mentioned a little bit about some anecdotal comments from physicians. I'm just curious, what would you say practices, doctors, or MOAs have been saying is specifically the greatest value to the practice of the program, or specifically to patients that has been a result of the program?
Well, from the perspective of support, I would say the thing that's been the most popular is the peer mentor support. The physicians and the MOAs we ask in the survey the physicians to rate the different aspects of support, so that we hear feedback on our PACs, on our peer mentors, on the vendors, and so on. And the most consistently positive is the peer mentor support. As far as impact on patient care, no one thing jumps out. We hear a lot about professional satisfaction. They were just frustrated before, and now they're feeling a lot better about it. A lot that are feeling like this is now allowing them to get out of the daily churn. They were just focused on seeing all the patients that were on their doorstep. Now they're able to reflect on the patient panel, become more proactive, and that's getting them reinvigorated about patient care. That's probably the most, personally, the most rewarding aspect of the whole thing.
Oh, great. The next question is around resources for Jeremy as well. How much time and effort does it take to support, say, a typical physician practice from assessment to the improved use in the process you outlined? So, but how much time and effort?
It certainly varies significantly by practice and type of issues and so on. I can say a few things. On average, we track the cycle time from when they engage in the process to when they complete. It generally takes on average about 6 months, and it's actually pretty consistently about 6 months from when they first engage to when they complete their progress assessment and are subjectively confirmed at level 3. During that time, the resources do vary a lot, but a practice optimization coach at minimum goes in and does an initial assessment and a progress assessment, and on average, I'd say at least one visit in the middle. So you're looking at about 4 to 5 hours per practice optimization coach. Multiply that by a couple thousand positions. It's a pretty significant investment, plus the peer mentor support.
Okay, great. Again, another one for you, Jeremy. As many other provinces are facing the same barriers around EMR optimization and meaningful use, would PETO consider sharing their post-implementation practice support program with other provinces?
Absolutely. In fact, we've had lots of discussions with our colleagues at Ontario MD. I'm sure some of them are on the phone with us today, and we're doing a joint presentation at the eHealth conference in June.
Oh, terrific. Great. Another question I have from one of our panelists is about the earlier data presented on productivity and the definition of that. Just a quick response that the National Physician Survey, where that question was posed, did not define productivity or quality. It was self-reported by physicians and what productivity or quality meant for them. Another question I have for you, Jeremy, is a panelist is wondering if there was any discussion or exploration of the burden of switching between EMR vendors. For example, when a vendor goes out of business or does not meet necessary standards, did any of your practices face the challenges of transferring data between EMR systems?
Sure. Sorry, Chad, just remind me the prior question briefly.
Sorry, did anyone in the program have to switch EMRs? And
no, the prior question.
Oh, the prior question I responded with, that was for me, and okay. I responded about the NPS question, so that was mine. Sorry, Jeremy. The next one for you. Did anybody?
So very, very few physicians have changed EMRs in the recent history. We had a number convert as part of the EMR implementation program from, say, older EMRs or non-qualified ones to newer ones. But in the last 4 years, very, very few physicians have actually converted EMRs. We do have our EMR to EMR data transfer specification, which many of the vendors have now implemented and are continuing to implement to ease that process. Doesn't make it easy, but it's a step. But there's been very little switch over between EMRs.
Okay. A question you mentioned also for you, Jeremy, that the meaningful use data is really helpful to understand, providing quality of care. Do you think this would be a good resource for researchers, and would PETO be making that available to researchers in the future?
Yeah, it certainly is valuable to researchers, and we've actually already had someone do a master's thesis based on the data. We'd have to deal with individual cases as to whether we can share it for other research, but I think that's possible.
Okay, that's great. Another question, we have quite a few questions actually on interoperability. I'm wondering, Jeremy, what would you see as the drivers to achieving interoperability in primary care?
Well, there's a number. The results and reports delivery is huge because that is such a high bulk of the amount of paper that comes through and helps with the timeliness of information, but also it gets data into the EMR in a way that is usable. So EMR adoption was very low in places where they didn't have electronic lab results delivery, for example. Because every lab result that came in would have to be re-entered by the staff. I mean, an absurd situation. But once you've got electronic lab results coming in, it flows in automatically. It goes into the physician's inbox. It's part of the workflow. You've now got structured lab data in there. You can graph lab data, et cetera, et cetera. It makes it efficient. It gives you new value that you didn't have before, and so on. Then you start moving to other things like referrals and e-prescribing and so on, and there's a different business case basically for each one of those things. Certainly for the physician, closing that gap on interoperability is tremendously valuable, because they've now got 85% of their information electronic. It's both inefficient and sometimes even risky to be co-managing electronic and paper environments.
Okay, one more question for you, Jeremy. What would you say are physician or practice demand in the future with respect to EMR use and optimizing their use of EMRs? Where would their demand be?
Oh, okay. Well, at this point, I'll speak to BC at the current point in time. So we've provided this intensive program to get physicians up to meaningful use level 3. So we're now looking at about 1,000 physicians who haven't been confirmed level 3 yet, and 2,000 to 2,500 who have. For the 1,000 that haven't, we're having a fair bit of discussion as to what should or shouldn't be available to that group in the future. And the challenge for them, as I mentioned, is the motivation. If they're nearing retirement or they're in a purely walk-in type practice, they're not really interested in these things. So something needs to change in a different aspect of the system to change that motivation to participate, to want to have good data in their EMR. So we're not seeing a lot of demand from that group. I mean, we've offered a program for the last couple of years of basically complete hand-holding and intensive resources. If they didn't want that, then they probably aren't that engaged in anything in the near future. So the 2,000 to 2,500 who have participated, we see two areas that they're keen to get into. One is quality improvement using the EMR, and the second is the interoperability.
Okay, I'm going to have one more question for you, Jeremy, and then we'll wrap up the session. What progress, and we've had a few questions around the structured data piece come in, what progress would you say has been made or is being made around physician entry of structured data or availability of structured data?
Well, that's been a big focus of this process, and it has improved significantly as a result of those physicians that are participating in this. It's really been amazing to me the number of just anecdotal cases I've heard of physicians who have gone through the subjective assessment, then run their ODD and found that they had 0% entered for height, weight, blood pressure, and so on. And they end up submitting their ODD and asking for an exception. Say, well, can I get an exception on those 3 metrics? And we'd respond back and say, no. Well, it depends. There are certain circumstances where those metrics aren't relevant if they are GP with a particular focus practice, say obstetrics. But in general, the answer would be no. And we'd have a discussion with them as to why those things are important. And I remember one particular discussion that I just happened to have. I ran into a physician, and I explained the importance of having height, weight, and blood pressure in structured data, because he was capturing it in the encounter notes in free text. And I said, well, if you've got it captured in structured form, now you can graph your blood pressure over medications to see what's changing. You can have clinical decision support alerts. You can start to have some quality indicators, et cetera, et cetera. And after about 2 minutes of discussion, he said, right, yep, I need to do that. And he went back and did it. And he actually, not only did he change his practice, but he went back and went through all of his past patients and moved the information from the unstructured notes into structured entry. So I think once physicians see the value, then they start to change practice.
Mm-hmm. Well, terrific. Thank you very much, Jeremy, for responding to all those great, and our folks on the webinar for submitting such great questions. We're going to wrap up the session today. So I just want to let folks know that the presentation will be available in English and French on Infoway's website. And in addition to that, we have a resource document available by province where you can contact direct support for optimization of EMR, as well as other resources nationally. In addition, I'd like to invite folks to visit our new website and explore that. There is information in our community section around our peer networks and so forth. And with that, I will thank everybody for joining today's call.